All right, so welcome back to our Meet the Expert series. Once again, this is our final instalment of the Meet the Expert series, and this time we're with Dr. Anna Keedwell, who is a palliative care specialist. She works in Albury and Wodonga hospitals, and she also sees patients in their homes across the region from Wodonga to Wangaratta and Benalla down to Mansfield. Anna says she's a late starter to medicine. She didn't start medicine until her mid-30s, and with the specific aim of going straight into palliative care. And she qualified as a specialist in 2022, and she's also a qualified GP. So with that, I will say welcome, Anna.
Thank you, Rose. It's lovely to be here.
It's excellent to have you. Thank you for joining us. So we usually start with the question about if you can tell us a bit more about your role in the region and what you do. Go.
So I'm a palliative care specialist, and I work with teams in the hospital and across the community to provide specialist palliative care to patients who need it. So I'm part of what's called a consultative service, which means that I don't have a ward of my own, unfortunately. I would dearly love to have a palliative care ward at Albury Wodonga Hospital. But we support other teams to provide the care by giving them advice and education and backup support as they're managing their patients. So I do this in the hospital at Albury and Wodonga, also in Wangaratta, and I assist the community teams from Wodonga, Wangaratta and Benalla and into the regions around there.
We'll talk a little bit more about your role later on. But first of all, tell us about how you got involved and what drew you to palliative care. What was your career path?
As you mentioned in your intro, I was a really late starter to medicine. I thought about it when I was 18, but was too scatty and running around and couldn't concentrate to get the marks. So I came from a background in public policy as a policy analyst, and then I started having lots of children and came to Australia from New Zealand. And once my kids went back to school, it was like my brain came back, and I thought,
Wow.
what am I going to do now? And I decided to apply for medicine. I've had quite a few people say, well, that's not what most people would choose.
No.
But I went into medicine saying that I wanted to do palliative care. I'd had some early experiences with death of friends when I was in my early 20s. And it really changed my view of death and dying. And I just became interested in that end of life. And when once upon a time, I would have thought that I'd want to become a gynecologist and an obstetrician, but actually I prefer the midwifery at the end of life.
Yes, yeah. That's a very common story. I think a lot of people who work in this field, both in the sort of the Western medicine model as well as more holistic approaches as well. Everyone I've spoken to, almost to a man or a woman, says that they have had some kind of experience, with death up close. Whether it was and it's been like a formative experience where it was the death of their mother when they were younger, or the death of a friend, and that's sort of drawn them to want to work in this field. Yeah. It's true.
Yeah, I think one of the things I've always liked about it is it's a very honest field of medicine.
Yeah.
Things are at the pointy end, and they can be quite raw, and sometimes people do not want to engage at this point, and that's fine. But mostly I really like the interaction with people most of all.
Yeah, that's what I love about it too, and that's what I'm always at pains to talk about when I deliver education to aged care staff, and it's that idea that palliative care is you're caring for the whole person, which means you've got to bring your whole self to it for it to be really effective and meaningful. And I think talking to people in aged care, particularly, that's what they say they love about aged care, is that you get to know the people, and you become much more a part of them rather than just fixing them up, get the appendix in bed 5 and out the door they go. That's why I love palliative care, because it is so it's so meaningful, isn't it? Yeah. and you get to relate to people on such a deeper level. Yeah.
Mm.
Yeah. So you've brought a lot of skills and your own self to palliative care. What would you say palliative care has given you? Like, how has it impacted you over the time that you've been working in it?
Interestingly, on a personal level, I think it's brushed off a lot of my rough edges. It's given me a lot of humility. I think I'm become kinder as
Mm.
a result of working in this area, and probably more generous, which in unexpected things I would have never thought that I would have said those were the qualities that came out of this area.
Yeah, that is so true. I couldn't agree more. Yeah. And I know I've been working in nursing for over 40 years, but the last 3 years in palliative care as a specialty, it's really taught me a lot, and those sort of things too. You start to realize the just the nuances of people, and you know, I tend to be a bit idealistic and sort of say we should be doing this and it'd be great, you know. And you often see people. And you make an assessment and you say, okay, well, we'll do this, and this, and it'll be all fantastic. And then the person says, no, that's just not going to work for me. I don't want to do that, or I don't want to do this part of what you're prescribing. And so, yeah, you become much more forgiving and allowing people to be themselves. You know, I say that people die the way they live, and so you can't just all of a sudden overlay something that's just not going to match them, because they've never done that all the way through their lives. So you've got to allow people to be who they are. Yeah.
Absolutely. I think the other thing that I've really enjoyed about palliative care is, well, there's a couple of things. One is the training has been very good. It's an interesting area of medicine. I mean, when you Google palliative care, you get an awful lot of hand holding or the pictures of the Grim Reaper. And I think there's quite a lot of medicine in between both of those. And I enjoy the opportunity to practice good, thorough medicine on people, and in a way that leaves people feeling cared for, noticed, taken seriously, and not abandoned.
Mm.
So that's one aspect that's been very good for me. And the second would be the teams, the people I get to work with, the colleagues, fantastic,
Mm.
generous people with interesting ideas, completely different backgrounds, different approaches. And it's an environment of continuous learning, of supporting each other to grow and become better clinicians.
Yeah.
That's been an amazing environment to be growing up as a doctor in.
Yes. Yeah, and it's true. Like I say, it's because of the because of the holistic nature of the work, it requires a multidisciplinary approach, and it means that it's a team approach, and that's often what I tell the aged care workers that I'm working with and delivering education to, is that the team is so important, because we can't do this on our own. It has to be a team approach. You know, you bring all the gifts and the talents and skills of everybody in the team, to meet that person with all of their sort of myriad aspects. So yeah, you can't actually deliver palliative care by yourself effectively. Yeah.
I always say that palliative care is everybody's business,
Yes.
and no one person does palliative care.
Mm.
And recent studies have shown that people who are under palliative care services, I mean, we might provide maybe 5% of their care. The other 95 or greater is coming from the support services around them. It's the people who they're at home with, it's family members, it's carers, neighbours, pharmacists, programs run, community programs, sports
Mm.
groups, the works.
Yeah. Yeah,
Yeah,
that's true.
it
And
really is everybody's business.
yes. And I always say palliative care is a team sport. That's my little catch cry. And yes, and in aged care homes particularly, that requires that team sort of home team approach from the staff to be so collaborative and to work together to come up with solutions to any issues that arise. I was going to say something else and I've forgotten it. Anyway, can you say something about the specialist palliative care role in the aged care environment and how you, as a palliative care specialist, can support our aged care workforce across the Hume region? Like how you might get involved and what sort of things you can offer.
Yeah. I really wish that we had the opportunity to be more involved or to have a continuous palliative care presence in the aged care facilities so that it became normal. It's not just when people get desperate. To be able to support the nursing staff on the floor, first of all, with, identification of patients who may have palliative care needs, and about how to care for those patients in a slightly different way. That's around education, or education also applies to the doctors who are supporting the nursing homes. And unfortunately, we don't have doctors permanently attached to nursing homes either. I mean, the quality of the care would be so much broader if we could have that multidisciplinary approach in-house. So our role is very much to support the people who are doing the work already. I'd like to see more education and support, particularly for the nurses, because there are many, many excellent nurses working in nursing homes with very good skills. And like anybody that I support, be able to teach them some of the information they need and how to troubleshoot and when to ask for help and where to ask for help.
Yeah. Yeah. Well, that's what Sam and I are always trying to do. 2 days a week each,
Across an entire region, so
yes,
a huge region.
And we're always trying to engage with the aged care homes. We have the Pepper program, which I think is really fantastic. It's a fantastic way of creating a more sustainable model in the facilities, because it sort of naturally creates, you spend 2 or 3 or 4 days with the same group of people, and it's a group of people. They've all gone through they've heard the same stuff and gone through the same training. And so now that little group of people who have obviously put their hands up because they're interested in palliative care now become the little palliative care posse in that facility. And then hopefully they will find strength in each other, and with management support, they can go on and continue improving palliative care practices in the facilities. And so
yes, I think that's very much about empowering, isn't it? And be able to speak out and recognize. One area that I'm interested in is that I know a lot of our aged care workers come from other countries with a different cultural background, and death is approached differently. And I'm not sure that we are working in that paradigm very well at the moment.
No, that's true.
I think we need to help people to be able to identify what their beliefs are and how that works with the system that we've got and how they can work together.
Yeah.
And that applies across the board as well, with a generalized death phobia that we're sort of context that we work in. And a lot of workers are young, and death is not that comfortable when you're young.
No, that's exactly right. Yeah. I remember, and I know I've been drawn to palliative care all my career, but maybe I'm just weird.
There's a few of us weirdos in here. Yeah.
And obviously there are plenty of young people in palliative care who do a great job, but I think too that there's wisdom that only comes with working in this field for a long time. And I would hope that there's enough people that can walk alongside the younger people, the younger health population, health workers, to impart some of that wisdom and to work together to share. And that's, again, we come back to the team sport. You know, you can't know everything until you sort of gain some wisdom and understanding. Yeah, so
I think coming back to your question about how we can help in palliative care and help in aged care facilities, is we're available for phone calls for help. Like a doctor can ring us at any time to say, I've got this patient, I'm worried about this, I'm not sure it's working, or in some cases, what do I do? They're dying. So we're there, and the other thing we do is we don't just do dying, is we do symptom management. And as you well know, Rose, people in aged care, you know, come with a long life and quite a
yes,
lot of illnesses in some cases,
yeah,
and multiple reasons to have symptoms such as nausea, pain, agitation, shortness of breath, constipation, some of these things, and also a lot of sort of psychosocial distress. And I
yeah,
think one of the things we can do is support through phone calls. We can come and visit and review patients in hospital. And so that will be, you know, specialist palliative care nurses from the community teams,
yeah.
also the doctors. So we have doctors like myself who are specialists, and also doctors who are training to be specialists, many of whom often come with an extensive medical background because they've chosen to come into palliative care after doing something else.
Yes, yeah, yeah. I think there's often a bit of confusion about, you know, when to call the pal care team in. Sometimes it's too early, sometimes it's too late, or it's not appropriate. But yeah, other times we see referrals and think, why did you wait so long? Because, you know, palliative care is core business in aged care, and as you say, people come with a whole bunch of pre-existing conditions that can often be fighting against each other, and sometimes the aged care staff, it doesn't occur to them that palliative care could have a role when you're dealing with like complex symptoms that are hard to manage, or resistant to all the usual sort of approaches, or even if the aged care staff have maybe a disagreement or a difficulty with the GP, working with the GP, and they're feeling like, you know, this person's not getting the care that they should. I think that's an appropriate time to at least reach out. And Sam and I are more than happy to take a call from any of the staff, any of you guys out there who are thinking, I'm not too sure what to do. I'm not too sure whether we should refer to palliative care or not. So technically our role isn't clinical, but we can advise you about where you might go next. You know, if you're having issues with the management of a patient, if you don't agree with the GP, or you've just got questions, or you want to suggest something to the GP and you're not sure how to go about it, you know, this is what we're here for. And we want to just make sure that you are all as well supported as possible, and that ultimately the residents and the people at the end of the care actually get the best care that they are entitled to. Yeah.
One other area I think we can definitely help in is about having those hard conversations.
Yeah.
I mean, how often do we see people who something happens and they get sent to hospital, and they are either in and out of hospital, or they have a prolonged hospital stay and often end up dying in hospital
Yeah.
after quite a lot of time. We're quite good at those conversations about, well, what would happen if this person was to become unwell next time? What would they want? What would their family want? Let's have some conversations about what's possible. Let's talk about allowing for a natural death rather than talking about what we're not going to do. We're not going to give you CPR. We're not going to send you to
Yeah.
intensive care.
Yes.
But let's see what's important to you. Would it be that you can die comfortably where you're familiar and not being in and out of hospital and being moved around and having tests and investigations? that might be one option. Or it might be that we do need to clarify that this is what we will do in the event of these things happening. And sometimes having those difficult conversations with families, because often people are not aware of what is happening to the person they love.
Yeah, that's often, I would say that's probably the number one anxiety that I hear from aged care staff. You know, if we start talking about palliative care and I say, what are your concerns? Families, they all come back to families. And yeah, communicating, it's at the heart of palliative care, isn't it? Like good communication and being brave enough to have the conversations. And it's not something that's easy. You can't just expect someone, you know, just plonk them in an aged care home and off you go. It's something that takes you know, to be sort of mentored through and have education about and be helped to be prepared to go there with those conversations. And it's not easy, you know, especially if they're, as we say, you know, younger people. It can be really daunting. And so oftentimes they'll just avoid it. And then, yes, then you end up with the resident who's bounced in and out of hospital several times and no one's actually had this conversation.
And I think often families don't realise what is involved. It's not the same as when you were young and you went and you got your appendix out and you got better and you went home and lived a nice long life.
Yeah.
It is traumatizing to go into intensive care, is devastating and trauma inducing at times. It's not pleasant. And sometimes being able to break things down into very simple terms to plain English and say, this is what's going on with Wilma. You know, we think, and lay it out gently and kindly. And what do you think she might want? Or Wilma, what would you like? In a way that's safe for people to talk about it and to then support the family in their distress about, well, I don't want her to die.
Yeah. Yeah, I like what you say about creating a safe space for those conversations. I think that's really important to allow a conversation like that to happen and to sort of be in the room and be prepared to go there. Because often you'll find everybody's carrying around stuff that they want to say, but they don't know how to say it. They don't want to bring it up. And so it often requires somebody from outside the family, like a healthcare worker, to come along and say, okay, let's just talk about this. And I think a lot of people actually do want to talk about it, but they're all thinking that no one else wants to talk about it. And so everybody's keeping quiet. And it can be so liberating and so fulfilling for everybody to have to open up and talk about that stuff, and for the family to say, I don't want you to die, but also then to acknowledge, but you're going to anyway. You know, look at this is the way, this is reality. I don't want you to go. And that's more an expression of love than you know, keep her alive at any cost sort of thing. And for someone to be able to guide a conversation like that and bring all those beautiful parts of that dynamic out, rather than constantly be up against a family member or family members who are sort of saying, why aren't you doing it? She should be going to hospital, and what's going on here, and be really defensive about it. Thinking, you know, being afraid, basically.
One of the big...
Go on.
Just saying, one of the big components of our training in specialist palliative care is about communication skills. Probably almost more than, probably aside from something like psychiatry, but very much we have a big focus on it because it's important to do it well. And I think by being able to ask us to come in and having staff present so we can model those conversations, it gives people confidence to have them themselves in future and think, oh, I saw that doctor do that or that nurse do that. I'll try it.
Yeah, and that goes back a bit to what I was saying about mentoring. You know, if you're working in a facility and you're anxious about having those difficult conversations, find someone on staff who seems to be more over it than you, and next time they go in and have a conversation, ask them if you can come along and sit in and learn that way. So observe, or get them to run a little education.
Absolutely.
Yeah.
Ring us up and ask us to come in. And what
Yeah.
would you like to talk about?
Yeah.
I'll talk to anybody, anywhere.
Yes, and I know there are quite a few of the aged care referrals we receive in Wangaratta that are about psychosocial issues and existential distress and or family discord or those sort of things.
You mentioned earlier on, Rose, that sometimes nurses need support or healthcare workers need support where perhaps they're finding it difficult to deal with the doctor who is looking after the resident.
Yeah.
And I think it can often be helpful to have an outside specialist team come in with recommendations to back them up and say, look, I really think we do need to start using some opiates with this person. These are safe doses. This is what I would recommend. And to give them the confidence that they are doing the right thing.
Yeah.
Because
Yes.
many doctors do feel very uncomfortable about medications at the end of life.
Yeah, and yeah, a lot of the time it's because the buck stops with them, and they need to feel trusting of the staff that if they write up an order that's got a little bit of leeway, that the staff know how to increase that at appropriate levels rather than go in hard with the 20 milligrams of morph subcut straight away or whatever it is. And that's what I'm always trying to achieve with the aged care staff, is to empower them so that they've got the resources, they know where to go and know where to find the information they need that's trusted and evidence-based. And so then they can come to the GP saying, this is what I know, I understand all this. Can you please give us this order? And then the GP sort of says, okay, you seem like you know what you're doing. I will then, work together. Again, it's collaborative, isn't it? Rather than GP feeling like they're doing it all by themselves.
Yeah, it's a team game.
Yeah.
We all support each other and support families and families support the person they love. And it goes round in circles. It's beautiful.
So can aged care facilities contact the consultancy team directly, or do they need to go through their local community palliative care team?
I think if a patient is known to the community palliative care team, then contacting the community team is the appropriate way to go. It's also entirely appropriate for nursing staff or healthcare staff to say, we think this patient needs some palliative care input, and make a referral directly to their local team.
Yeah.
Who will then look at the referral, discuss it with one of the doctors often as well, and then make a time to go out and see whoever's needed to be seen. That can happen as a one-off, or it might be an ongoing relationship where there's sort of backup support ongoing.
Yeah.
So if a patient's known to the palliative care team, that's their first point of contact, is to ring and get advice. If the palliative care service is a day business hours service, they have an after hours number to call.
Yeah.
You are welcome to call that any time. People are awake, ready to take phone calls, so you are not disturbing somebody.
Yes.
The second thing is, I think, particularly for medical staff needing palliative care advice, that is a good time to call the triage phone number at the Albury Wodonga Health and ask to speak to a palliative care specialist.
Or Shepparton, if this is going across to West Hume as well.
Yes, of course. So Albury Wodonga Health covers the Wodonga region out towards Corryong, up to the border that way. Then we've got Wangaratta covering out to Bright and Mount Beauty, and Benalla down to Mansfield sort of region. That's all comes under the Albury Wodonga Hospital Specialist Palliative Care Service. And then on the other side of that sort of region, to the eastern side, is Shepparton.
Yeah. Yeah, sorry, I interrupted you. Yes. So yes, call the triage number at Albury Wodonga Health for palliative care specialist input.
Do you want the triage number?
Yes, that'd be great.
So if a doctor particularly is needing some advice, on the spot advice, one-off advice, or just generally has questions, you can ring the palliative care service, and we have a triage phone number rather than going through the hospital switch, but you can do that as well. The phone number, which I'll give to you today, is 0417 653 866. So that's 0417 653 866. And a doctor carries that phone during business hours, Monday to Friday.
Excellent. That's great to know. Yeah. Is there anything else you'd like to particularly say to our aged care workforce? Have you got any particular messages that we haven't covered already?
I think you're doing a great job. It's a wonderful area to work in. I wish it was more supported, more valued, and you were recognised. And I don't even know how to say it. It leaves me sort of feeling dismayed at times that your work is unrecognised, and you are very skillful, and we want to support you with that.
Yes, it's very difficult, very challenging. Yeah, definitely.
The other thing I would recommend is, if you have an interest in palliative care, is to do some training, and there are various modules that are available online and are free as a starting point. They can help build up a framework of knowledge in your mind. If you or other people would be interested, we always need palliative care volunteers. These are people who go in and come and sit with people, spend time with people who have a palliative care trajectory, support respite, sort of almost not respite, but support carers.
Yes.
And it can be a very rewarding voluntary work. So if you do know of anybody who might be interested in it, please just get them to contact their local palliative care service.
Yes, I think COVID really decimated the volunteer crew, particularly at Wangaratta. I'm not too sure about other places, but I assume that
I think it's been across the region.
Yeah.
And all the volunteers, well, volunteering is not for everybody in the palliative care arena. The people who do it find it immensely satisfying, and it's not an onerous role, but we value volunteers so highly.
Yeah, and you do get back so much from it. Yeah, it's same with working in the palliative care field. You know, if anybody out there is feeling inspired to do proper study and go into palliative care as a specialty, I highly encourage you to do that. It's not a field that's going to go away anytime soon, so you'll always find some work. And it's so rewarding. That's why I love to do it. It's interesting how you often, I don't know, you probably get this too, Anna, when you tell people what you do, and the first response is, oh, isn't that, oh, you're an angel, oh, that's really hard. And when you find the thing that you love to do, it almost doesn't feel like work a lot of the time. It's just
privilege.
Yeah, it really is. Yeah.
And I always say to people when they say that, one, that it's a privilege. I'm allowed into people's lives and their homes, and that's an honor. And it's not my sister, it's not my friend, it's not my husband. So I can separate myself out from it.
Yeah. Yes.
It is a job, but it's a job that I do with compassion and kindness.
Yes. Yeah. We love kindness. Okay. Well, thank you so much for your time today, Anna. I really, really appreciate it. It's lovely to have a chat with you. And we will see you again soon. Okay.
That's delightful. Thank you. And I look forward to being able to spend a little bit more time in aged care facilities.
Yes. All right. Thanks. Bye-bye.
Okay. See you later. Bye-bye.